Good evening, everyone. Welcome to tonight's webinar entitled It's All in the Limbs, Lymphedema and Cellulitis, brought to you by Capital Health Network, together with Dr. Elizabeth Webb of the John Curtin School of Medical Research and Josie Radnich of North Canberra Hospital. First, I would like to acknowledge the Ngunnawal people as the traditional custodians of the land on which we meet today and pay our respects to elders past, present, and emerging. I also extend that respect to any First Nations people joining us today. Now, my name is Sheila Brito, and I'm the Allied Health Engagement Officer at Capital Health Network. Also with me tonight are the Education Lead at CHN, that's Kunal Mohite, and lymphedema physiotherapists, Dr. Elizabeth Webb and Josie Radnich. Now, just a few things before we start. There'll be an opportunity to ask your questions after both presentations have finished. Please type all your questions and comments into the Q&A section, not the chat box of the side panel of your Zoom window. Now, regarding CPD, please fill in the post-event evaluation survey rather. CHN will email you a certificate of attendance after the event. Do feel free to self-report 1.5 hours of educational activities to your CPD home. Now, as a reminder, the Health Pathways website has guidelines and advice on investigations, treatment, and referral pathways on many conditions, including lymphedema and cellulitis. If you do not have your personal login details, you may use the login together, which is the username, and for health is a password, and that's one word, FOR health. And now over to our presentation. So our first speaker is Dr. Elizabeth Webb. Dr. Webb is a lymphedema physiotherapist and research fellow at the John Curtin School of Medicine at ANU. And in 2023, she received the CHARM Outstanding New Researcher Award. Her notable research includes a randomized controlled trial demonstrating that compression therapy can reduce the recurrence of cellulitis in patients with chronic leg swelling by 77%. Now, this study has influenced clinical guidelines globally and is being implemented in medical practices worldwide. Over to you, Lizzie.
Thanks, Sheila. I'll just wait for the PowerPoint to come up. And thank you for that kind introduction. So today I'm going to talk a bit about what cellulitis is. I'm going to discuss a little bit about differential diagnosis, risk factors for cellulitis, and how to prevent them. How to prevent cellulitis studies through risk factor management. And I mainly focus on cellulitis of the leg because that's where it's most common. And I just want to note that I'm approaching this topic as a lymphedema physio, and I have a strong interest in cellulitis, and I've delved into it deeply because of my research and because it impacts so many of my patients, but I'm not a doctor, I'm not a medical doctor, and I haven't had a lot of involvement in management of acute cellulitis. Sheila, are the slides coming up? I can't see them, but I'll just keep talking while I wait for the slides to come up, because basically I was going to talk, to start with, I'll just talk about what cellulitis is. So it's a common acute bacterial infection of the skin and the subcutaneous tissue, and it presents as a poorly demarcating red spreading rash with associated heat, swelling, and tenderness. And erysipelas, I just want to mention, is also a very similar infection to cellulitis caused by similar pathogens, but it's more superficial, involving the dermis only and not the subcutaneous tissue, and it presents as well demarcated erythema. And the terms tend to be used somewhat interchangeably, and most of what I talk about today refers to both cellulitis and erysipelas. So with cellulitis, the infection often arises from a break or a fissure in the skin, such as a wound, an ulcer, an insect bite, a dermatosis such as eczema, which will allow entry of bacteria. And cellulitis can really occur anywhere on the skin, but the most common location is the leg. And so about 80% of cases will occur in the legs. And they're almost always unilateral. So bilateral lower limb cellulitis is extremely rare, which I'll talk about again in a little bit. And although cellulitis is often mild, it can be quite severe, requiring hospital admission, and it has some possible severe complications such as bacteremia and sepsis. Um, and some of the longer term consequences of cellulitis include recurrent infections, chronic leg swelling, and skin ulceration and discoloration. And those consequences relate to tissue damage from the infection. Um, sorry. Oh, sorry, the PowerPoint's just skipping through a little bit. Not quite sure what happened there. Okay, so I was also just going to talk about how common cellulitis is, because for such a big issue, it's actually that not many people know about. It really is incredibly common. So in Australia, it's consistently one of the leading reasons to present to an emergency department and for hospital admission. So for the past few years, there's been roughly 130,000 emergency department presentations for cellulitis every year. And over half of those, between 50 to 60%, are usually hospitalized. And these figures are particularly large because about 90% of cellulitis is managed in primary care. So those enormous figures are probably only accounting for about 10% of cases. And cellulitis is also really expensive. So, an average hospital admission for an episode of cellulitis deemed of major complexity costs around $8,000 with an average length of stay of 6 days. And minor complexity episodes still cost nearly $4,000 with an average length of stay of 3 days. So, back in 2018, we worked out that this cost the public hospital system around $420 million. Uh, and one of the big issues we have with cellulitis is that it commonly recurs. So 30 to 50% of patients who have an episode of cellulitis will have another episode within 3 years. And unfortunately, compared to an initial episode, these recurrent infections are often more severe, they have an increased inflammatory response, and they result in longer hospital admissions and use greater resources. And there's no clear statistics I've seen that show what proportion of total cellulitis cases are recurrent, but I think we can assume from these figures that a big proportion of cases are for repeat infection. So if we can reduce recurrence, we can reduce incidence of cellulitis significantly. So cellulitis often stems from unmanaged risk factors. And this image shows that risk factors can be split into three main areas. So, any conditions which impair skin integrity, vasculature, or immune function can predispose individuals to cellulitis. The skin provides a physical barrier which prevents the invasion of pathogens. The immune system defends against and clears pathogens, and intact vasculature is required to maintain skin integrity and support the immune system by maintaining homeostasis and transporting immune cells and nutrients. So, risk factors for cellulitis you generally involve a deficiency in one or more of these areas. And so, the main systemic risk factor for cellulitis is obesity, although age is also thought to be a predisposing factor because of its impact on those three main areas of vasculature, skin integrity, and immune function. Local risk factors at the site of infection include edema, venous insufficiency, toe web infection or fungal infections, and skin barrier disruption. And the risk factors for recurrent episodes are similar. And of these risk factors, chronic edema is the most prominent risk factor for infection for cellulitis recurrence. And it's widely believed that management of these risk factors will reduce cellulitis incidence and cellulitis recurrence. And although there's little research in this area to support the hypothesis, there's sound logic and anecdotal evidence that suggests this is correct. Um, so I just was going to mention, for anyone who's unfamiliar with the term, I was just going to define what chronic edema is, because I talk about it a lot in this presentation. But Josie is talking after me and she will go into this in more detail. But the terms lymphedema and chronic edema are sometimes used interchangeably. However, chronic edema has been proposed as more of an umbrella term for persistent swelling regardless of the underlying cause, and therefore it refers to swelling resulting from conditions such as venous insufficiency, obesity, immobility, and heart disease. So when we think about chronic swelling and lymphedema, I think people's brains often go straight to cancer-related lymphedema resulting from the removal of lymph nodes. However, in Australia, there's not great data to show this, but I think the most common cause of chronic edema is likely obesity and venous disease. And chronic edema of the legs is particularly common in our elderly population, with about 50% of those in residential aged care having chronic edema. Okay, and so the relationship between cellulitis and chronic edema is very strong, and it's a vicious cycle. So for patients with chronic edema, so they've got leg swelling, their compromised lymphatic drainage not only leads to swelling, but also to impaired immune function, increasing their susceptibility to infection. And then the cellulitis infections damage lymphatic vessels, impairing lymphatic drainage, thereby increasing residual swelling and the risk of future infections. And this relationship is really strong. So, research out of the UK has shown that for patients with a history of recurrent cellulitis, almost 70% have chronic edema. And for patients with a history of one episode of cellulitis, almost 60% have chronic edema, with a large proportion of these patients having swelling before they ever had the infection. And a further large international prevalence study found that of almost 7,500 patients with chronic lower leg swelling, 16% had suffered a cellulitis infection in the past year, and almost 40% had experienced an episode during their lifetime. So basically, among patients with cellulitis, chronic edema is common, and among patients with chronic edema, cellulitis is very common. So why does chronic edema increase the risk of cellulitis and cellulitis recurrence? Ultimately, there's theories, but we don't really know. There's not any good evidence to support our theories. So we know that the lymphatic system plays a critical role in detecting and clearing pathogens, but in patients with chronic edema, lymphatic drainage and function are impaired, and this weakened immune response may increase the risk of cellulitis. Additionally, it's been theorized that chronic edema may predispose to cellulitis, as it can impair skin integrity, increasing susceptibility to entry of bacteria via the skin. And lastly, a now somewhat outdated theory is that edema increases cellulitis risk because it provides an excellent medium for bacterial growth. I hope not too many of you can hear my daughter in the background. She's not very happy. So differential diagnosis of cellulitis. Recognizing cellulitis and particularly differentiating it from other conditions that present similarly can be really tricky. So prompt treatment of cellulitis is critical to reduce the risk of symptom deterioration and possible life-threatening conditions such as sepsis, and also to avoid and minimize further tissue damage and damage to the lymphatic vessels that's caused from that inflammatory response, which may then predispose patients to further morbidity, including repeat infections. So when diagnosing cellulitis, there's no specific laboratory test for cellulitis, and therefore the diagnosis is based on clinical features and patient history. And so the clinical features include poorly demarcated and spreading redness, heat, swelling, and tenderness local to the involved area. And the infection, as I said before, is almost always unilateral. So if signs appear bilaterally, alternative diagnoses need to be strongly considered, particularly in the legs where there are multiple differential diagnoses that present similarly to cellulitis. Patients often have accompanying symptoms such as fever and malaise, and some patients will develop systemic symptoms before developing local symptoms such as the spreading redness, which can sometimes confuse and delay diagnosis. And that seems to be more common in patients with lymphedema, but it can make it tricky. Although non-specific, inflammatory markers such as CRP, white blood cell count, and ESR are usually raised, so the absence of elevation makes a diagnosis of cellulitis less likely. And other possible clinical signs include things like a portal of entry, such as a wound or a fungal infection between the toes. There can be skin breakdown or blistering in the area of infection. There may be swollen lymph nodes and inflamed lymphatics proximal to the infection, which can appear as sort of a red line tracking up the limb. And there can be wide variation between patients in how they present, but pain is almost universal, pain and tenderness, and generally the main complaint for patients. And patients who experience multiple repeat episodes will often find that the repeat episodes present similarly to their last ones. In terms of cultures of needle or biopsy aspirate at the lesion site, they don't normally detect the pathogen that's involved, and so it's not routinely indicated for patients, but they are recommended if there's an open wound, drainage, or a clear point of entry for bacteria, because then it's more likely that the pathogen will be identified. And so misdiagnosis of cellulitis is really common, particularly in the lower legs. It's diagnosis of cellulitis is not straightforward because there's so many other possible causes of red legs. Although for those other conditions, often the redness is bilateral. And studies have shown, a couple of big studies have shown that roughly about 30% of cellulitis diagnoses are wrong. And so these photos show conditions that are commonly misdiagnosed as cellulitis. And I think when you look at these pictures, it's easy to see why. So some of the conditions that are misdiagnosed as cellulitis include lipodermatous sclerosis, venous eczema or gravitational dermatosis, contact dermatitis, fungal infections, DVT, drug-induced edema, and underlying medical conditions such as heart failure, and apparently heat-induced redness, although I haven't seen that as a misdiagnosis before. And notably, many of these conditions actually, are sequelae of vascular disease and also cause swelling. So I think lipodermatous sclerosis is the most common condition that's misdiagnosed as cellulitis. And acutely, it can occur unilaterally, but chronically, it's often bilateral, and there's bilateral changes that are seen across both legs. And so the term red legs or red leg syndrome, I think I just skipped, has been coined to describe conditions that are misdiagnosed as cellulitis due to their presentation. So because their signs include bilateral lower limb redness, pain or discomfort, heat and skin changes, they're often misdiagnosed as cellulitis, but most of these conditions will present without any systemic symptoms such as fever and malaise. And as I said before, they're mostly due to vascular disease, and while they can be acute, they're more commonly chronic, and accurately diagnosing these conditions is essential to ensure correct treatment is prescribed and unnecessary antibiotics are not given. So for those 30% of patients that are misdiagnosed, many of them receive multiple prescriptions of antibiotics that don't help. And this is a really great resource that's available through the British Lymphology Society. It used to be called the Red Legs Pathway, and now it's called the Lower Limb Inflammatory Pathway. And it's been designed to help clinicians differentiate between lower limb inflammation of other causes and cellulitis. And it also provides some recommendations about treating lower limb inflammation, for which treatment often involves really good skincare, use of emollients, use of topical steroids, and compression therapy. And this is the Legs Matter website, which is also just another great website for people to have a look at because it's got a whole lot of great resources for clinicians and patients. I've learned a lot by looking at the resources on there. And so if you suspect a patient has been misdiagnosed with misdiagnosed, we recommend contacting or sending them to their GP to have a discussion with their GP. And when necessary, it might be appropriate for them to see a specialist, such as a dermatologist, for skin conditions, or a vascular service if there's suspected vascular disease, such as lipodermatosclerosis and venous eczema. And so treatment of cellulitis, I'm just going to touch on lightly, and then I'll go into prevention. But treatment of cellulitis requires antibiotics, which may be oral or IV, dependent on the severity of the infection, and location of treatment, whether it's outpatient, community-based, or hospital-based, also depends on the severity. And as I said, I'm a physio. This isn't my area of expertise, but cellulitis is typically caused by streptococci, group A strep, the most common cause, and less commonly caused by Staph aureus. And therefore, treatment is antibiotics that target both of these organisms, so flucloxacillin. And for atypical infections, such as where it's thought that the organism might be different to these, so if the infection was from, say, a human or an animal bite, other antibiotic regimes may be recommended. And the Australasian Lymphology Association and the British Lymphology Association both have guidelines for medical practitioners which give specific information on type, dose, and duration of antibiotic treatment for managing cellulitis in patients with chronic edema, lymphedema. And monitoring the response to antibiotic treatment is essential. So for patients deteriorating and not responding to antibiotic treatment within 48 hours, then further medical assessment is warranted. And so now I'm going to talk about preventing cellulitis, which is where I've gotten involved in research, and sort of is one of my passions. So like all health conditions, education empowers patients to make decisions to improve and maintain their health. Qualitative research has shown that patients with cellulitis would like more information on what's caused their infection and how to prevent it, with many patients really lacking an understanding of both of those questions. Management of risk factors such as chronic edema helps to reduce cellulitis. And lastly, there's evidence to show that for patients with recurrent infections, low-dose antibiotic prophylaxis does reduce the risk of recurrence. So cellulitis prevention, I should say, is also, it's not only important for patients who've had one or repeat infections, it's also really important for patients who are at high risk of cellulitis. So for example, for patients with chronic edema or venous insufficiency who have a high risk of developing cellulitis during their lifetime, it's really important they have education to inform them on what it is and how to reduce their risk of getting the infection. And so antibiotic prophylaxis recommendations vary, but they are often recommended for patients who've had repeat infections despite modifiable risk factor management. And the ALA and the Australasian Lymphology Association and the British Lymphology Association have guidelines recommending prophylactic antibiotics in high-risk patients, with the ALA guidelines stating that antibiotic prophylaxis should be offered to lymphedema patients who've had 2 or more episodes of cellulitis in a 12-month period, despite diligent skin care and treating all the contributing risk factors. So risk factor management is normally the first line approach, but if that's not working and there's still repeat infections happening, then antibiotic prophylaxis is to be considered. And the BLS offers similar advice, but also notes that the decision for antibiotic prophylaxis should be made in conjunction with a specialist lymphedema service, taking into consideration if the infections or the episodes of red legs were truly cellulitis, if the episodes were truly individual and not just a sort of a repeat flare-up, and also, again, ensuring that any reversible causes have been removed. So for patients for whom prophylaxis has been successful and they've had no further infections, the guidelines then give advice on reducing the dose and ceasing antibiotic prophylaxis after 1 to 2 years. But they do acknowledge that for some patients with particularly high risk and unmodifiable risk factors, prophylaxis might need to be lifelong. And although some people on this webinar this evening might not be involved in prescribing antibiotics, I think it's still important to know about this and important to know about these guidelines, because we can tell our patients about these guidelines and about this information, and they can have a conversation about them with their medical practitioner about this to see if it's relevant for them. And so although there's very little research and therefore evidence to indicate that management of other risk factors will reduce the risk of cellulitis, without evidence to the contrary, it's logical to assume that it does, which is why most guidelines recommend risk factor management to prevent cellulitis. And so obviously there are some risk factors we can't treat or modify, such as age or a history of trauma. But to reduce risk, we tend to focus on modifiable risk factors. So skin integrity, fungal infections, presence of edema, venous disease, and obesity are the risk factors that we think about. It's arguable whether obesity is actually a modifiable risk factor, but it's at least important for patients to know that it's a risk factor and to support them to prevent further weight gain. And so skin integrity, so healthy, intact skin optimizes the natural barrier function of the skin, which acts to prevent bacteria from entering the body and causing infection. So skincare to optimize skin integrity includes regular moisturizing with emollients and creams, educating patients about avoiding cuts, scratches, and bites through things like long sleeve clothes and good footwear. Instructing our patients that if they do get a cut, a scratch, or a wound, they need to care for that appropriately, keeping it clean and covering it up, possibly an antiseptic cream. And then for patients with ulcers or more substantial wounds, we want to make sure that they're receiving appropriate care through their GP or a wound care nurse. And it's also really important for patients that have skin conditions that could predispose them to cellulitis to manage these appropriately. So if they have a dermatitis, such as eczema, they should be using steroid cream appropriately to make sure the skin condition doesn't deteriorate and allow bacteria in. And good skin hygiene can also reduce the chance of bacterial colonization. Fungal infections increase risk of cellulitis, and they're detrimental to skin integrity, and they provide portals for bacteria to enter. So tinea pedis is a fungal infection that is particularly common in patients with chronic swelling. It begins between the toes, commonly occurring in people with sweaty, damp feet. And signs include itchy, macerated, scaling lesions or rashes. And it's contagious, can be spread via contaminated floors, such as at swimming pools. So treatment involves of the interdigital fungal infections involves application of Lamisol daily for a couple of weeks. And to prevent further infections, we then recommend patients dry thoroughly between their toes after washing and wash their socks regularly. And for patients who are really struggling with this, we encourage them to go and see a podiatrist or a pharmacist for further assessment and advice on management options. Okay, and so chronic edema, which is where I've done my research around preventing cellulitis. And so a few years ago, when we started looking at the literature, we realized that, like many of the other risk factors, although there's a lot of guidelines that say you should manage chronic leg swelling to prevent cellulitis, there was no research on this. And I think that's something that we thought was really important to change. And so my team and I conducted a randomized controlled trial that looked at the efficacy of compression therapy in preventing recurrent cellulitis. And I won't go into this in great detail today, but the results show that compression therapy was very effective at preventing cellulitis. And in fact, providing for patients who are having repeat infections and who have leg swelling, we found that compression therapy reduced the risk of cellulitis reoccurring by 77%. And we stopped the trial early because the impact was so clear. And we also found during this research that compression therapy, because it was reducing cellulitis incidence and hospitalizations, it dramatically decreased healthcare expenditure and also patient health-related expenditure. So there were benefits all round. And so we now can definitely recommend compression therapy to prevent repeat infections of cellulitis. And although this research was specifically related to recurrence and it was specifically related to the leg, in absence of broader research on the area, I think we can apply that evidence more broadly. And so, for example, I think compression therapy to control leg swelling likely prevents first infections or prevents recurrence in patients that haven't already had multiple repeat infections. And it probably also applies to other limbs like the arm as well. But importantly, compression therapy to be effective needs to fit properly. And so it needs to be prescribed to individual needs. Some of these patients need compression bandaging initially to reduce their swelling before they go into a compression garment. We recommend compression garments are worn daily and updated every 6 months. And we teach these patients how to get the garments on and off, and we provide them with or show them how to use compression aids. Oh, sorry, yeah, aids, application and removal aids if required. And so this is some of the compression garments we used in the trial. And obviously, compliance is a really big issue with compression, but we had within our trial, we had really good compression, really good compliance. And I think that's down to the fact that we worked with the patients to ensure that the compression was individualized to their needs. And so prescription was individualized to each patient based on the severity of their swelling, the size and the shape of their limb, the skin quality, their ability to get the garments on and off independently, and of course their preference. And with many of these patients having a lot of comorbidities, and they can find it challenging to manage their many health conditions, we knew that if something doesn't seem like a priority or management seems too hard, it's often going to slide. So we really focused on just making sure that they got into something that they could tolerate and something they could get on and off. And even therefore, if it wasn't as strong a compression as we wanted to be, it was something, it helped control their swelling and they could manage it by themselves. So that was a real focus for us in this trial, was making sure that the compression therapy suited the patient, and that they could use it and were happy with it. And so the other two risk factors I'm going to briefly mention that we target are venous insufficiency and obesity. So venous insufficiency occurs when the valves in the veins fail, leading to blood pooling and increased pressure in the veins, and consequences of it include swelling, skin changes, such as hemosiderin staining, itching and discomfort. And both the swelling and the skin changes likely increase the risk of cellulitis. And again, targeting venous insufficiency often involves compression therapy. And so getting these patients into compression is really important and will stop the venous insufficiency progressing over time. But it's also important that these patients are linked in with vascular services for a professional review. And obesity management is also really important. It's very, very complex. But we often look to link patients with weight management services that could be useful, and with evidence that maintaining weight loss can often be sustainable. For some patients, weight stabilization and prevention of further weight gain might be a good goal for some of these patients. And I haven't mentioned exercise, but I think it's always essential that we talk to our patients about the benefits of exercise, which also help with leg swelling. And so, sort of in summary, the education that our patients really need to receive is what cellulitis is and what the signs and symptoms of it are. I've dealt with so many patients who've had multiple episodes of cellulitis, and they still really don't understand what the infection is. They really don't always know clearly what the signs and symptoms are, and they definitely don't know their risk factors. So I think telling them about what their risk factors are and how they can decrease their risk is really important. And that information can be tailored to them based on their medical history and their specific risk factors. And they just need to know what to do at the onset of infection too, so that they can go to a GP, they can go to a walking centre, or if the infection's progressing really quickly and they can't get into one of the other services, they should go to an emergency department. And also some patients will keep sort of prescriptions have sort of an in-case prescription of cellulitis that they can start straight away if they know they're having another episode of cellulitis, so that they can get onto it straight away. And that's particularly important if a patient knows they're traveling somewhere where they might not have access to medical services and they know they're an at-risk person. And so in conclusion, cellulitis is very common. It's often recurrent. Clinical diagnosis is challenging and it can often be misdiagnosed, but being aware of the signs and symptoms can help us recognize it and differentiate it from other conditions. And prevention involves education, risk factor management, and possibly antibiotic prophylaxis for high-risk patients. So that is me, and over to Josie.
Thank you very much. I'm just going to switch the slides over. Just checking that you can see my slides.
Not yet, Sheila.
Not yet.
Not yet.
All right, let's try that again. We've been having a few technical issues tonight, haven't we? Try that again, please bear with me.
Looking good.
Looking good. Have I got the start?
That's better.
All right, thank you very much. Now, I'd like to introduce our second speaker, Josie Radnich. Josie is the Acting Lymphedema Service Coordinator and Senior Clinician at North Canberra Hospital Lymphedema Service. She's a registered physiotherapist and accredited lymphedema practitioner. Josie has further qualifications in the management of complex lymphedema presentations in the head and neck, genital and pediatric conditions, and in patients with wounds and chronic edema. And she has managed lymphedema in various settings within public, private, palliative, and aged care. And so I give the floor to you, Josie.
Thank you, Sheila. Okay, so I'm just seeing if I can change the slides as well. Click. Let's see. I don't quite have control of the slides.
I think it takes some time, but I can click it for you if it's not working.
Yeah, I'll get you to go to the next slide. Thanks, Sheila. So thank you very much for listening to me. It's very hard to go after Lizzie because She's a bit of a rock star in our world with her research. As Sheila said, I'm the acting service coordinator at the lymphedema service at North Canberra Hospital. So just a little bit about us. We're a weekday ambulatory service and we're run by the physiotherapy department. So we're a team of 6, so it's myself and 5 other physios. And we manage patients with or at risk of lymphedema, and they can be from the ACT, surrounding New South Wales, and we've even got one from Victoria at the moment, interestingly. So we operate via a hub and spoke model. So most of our appointments happen on site at North Canberra Hospital outpatient, physio outpatient department, but we also offer outreach lymphedema clinics at Belconnen, Gungahlin and Tuggeranong community health centres, just because getting into North Canberra Hospital, many people would appreciate can be hard. Even just finding parking can be hard. So we try and sort of spread out where the demographics are, where the need is. We also support the running of a lymphedema clinic, which is run by a vascular specialist and one of our senior lymphedema therapists, and that happens on site at specialist outpatients once a month. And just a little bit of warning at the beginning, we do currently, just due to sort of unprecedented demand, we have a significant wait time to attend the service, and it is currently somewhere between 4 to 10 months, depending on the triage category. So I will be providing details on how to refer to our service at the end, but I think just understanding that that is the wait time at the moment, sometimes just so that you can set some expectations with your patients. And what I'm hoping to do tonight is not just sort of tell you how to refer to us, but tell you how you can empower your patients to start management, if they're waiting to see us, or maybe they may not even need to see us if they can help manage that. I'll get you to go to the next slide. Thanks, Sheila. Okay, so a little bit of a summary about the lymphatic system, because if your undergraduate degree was anything like mine 25 years ago, I didn't learn anything about the lymphatic system. So we've got a picture of the lymphatic system there. So the lines are the lymphatic vessels. So their job is to collect that interstitial fluid, often just sort of just underneath the skin, and it transports it to the venous system. So it goes in sort of deep and central and ends up back in the venous system. The lymph nodes are all the little dots around, so lots in our armpits, groin, head and neck, and then deep within the abdomen. They filter the lymph fluid and act as a maturation site for the lymphocytes. So they're little garbage detectors. And there are lots of lymphatic organs that people are often even unaware that they are part of the lymphatic system. So that includes spleen, thymus, tonsils, lymphocytes, and Peyer's patch. So next slide, please, Sheila. Okay, so what does the lymphatic system do? Because most non-medical people have no idea, and sometimes we need a little reminder. So it's all about maintaining fluid balance, so that homeostasis. So it returns the fluid and the protein from the interstitium to the venous circulation. It also has an immunological function. So that's where those lymph nodes are sort of finding cancer cells and microbes and foreign cells and responding to them. And it's also responsible for removing waste products. And it also promotes fat absorption via those intestinal lymphatics. So it's responsible for that transport of protein, fat, and fat-soluble vitamins. Next slide, please, Sheila. So Lizzie's already done a definition of chronic edema, and really we do sort of use this term interchangeably these days. I think lymphedema people get a bit confused about and start calling it other things, but really any swelling that's sort of really been around for a while, so at least 3 months, we refer to it as chronic edema or lymphedema, because that sort of has generally caused some damage to the lymphatic system. So it's going to become, it's a chronic progressive disease. And it can happen, probably most of the time you're going to see it in bilateral lower limb. But obviously with those cancer related ones, you can see it in sort of single limbs or trunk, breast, head and neck, genital, lots of different areas. We're seeing a lot more in the abdomen now with our morbidly obese population too. Next slide, please, Sheila. Okay, now we're going to go on to the risk factors, because they're sort of things that are going to jump out and you'll go, oh, okay, yeah, I'm going to look out for this. So next slide, please. So there are many, and I think that's why lymphedema, it has such variable presentation, because it really depends on the cause. So widely known is often malignancy and cancer treatment. So any removal of lymph nodes, radiation to a particular area, chemotherapy, particularly taxane chemotherapy, increases people's risk. And the main thing with cancer treatment is often the more nodes, the more chance they have of developing lymphedema, but they're not all going to, which is good. Trauma or surgery, so significant trauma, can damage the lymphatic system. As Lizzie has just explained, infection. So we've got that vicious cycle with infection, cellulitis and chronic edema. Another one that's, really showing up a lot in our clinic, obesity, because we know that excess weight puts stress on the lymphatic system. So we have a lot of obesity-related lymphedema. And just a little fun fact, we did an audit of our service last year, and almost 20% of our patients attending our clinic had a BMI of over 50, so putting them into that extreme bariatric level, which sort of has lots of complications in terms of providing service to them. So other reasons why we can get chronic edema: reduced mobility and prolonged limb dependency. So our wheelchair-bound patients, or patients have, that are really not moving much. Obviously, we've got our, congestive cardiac failure, renal failure, venous disease. Lizzie touched on that. Hyperproteinemia, so abnormally low protein in the blood for various reasons. People with older age. I think Lizzie quoted the percentage of people with chronic edema in nursing homes. And then there are a lot of medications that can cause edema, and we come across those. And obviously, as a physiotherapist, it's not our area to prescribe or recommend anything to do with medication, but we see a lot of edema sort of with patients who are taking things like, Lyrica, antihypertensives, non-steroidals and steroids. And interestingly, we just had a patient, one of our our regulars that's been coming for many years, and he had to come in quickly because his stockings were falling off because his GP had changed his hypertensive medication, so amlodipine, and he had reduced his edema by a third in each of his legs, just for changing that medication. So certainly for those of you who do have qualifications to be prescribing medication, I think sometimes if you've got someone with chronic edema, having a review of their medicine to see if there are any changes that can be made. And a little note just in underneath that, we see a lot of people on fluid tablets, so frusemide. And I just wanted to sort of just say it does not control chronic edema. We see a lot of patients on it. And I mean, obviously there are other reasons why they might be on it, but we might usually have a chat to our patients and say, look, have a chat to your medical professional and just work out why you're on frusemide. Obviously, if it's for a cardiac reason, then that's great. But it's a conversation that usually needs to be had, because it's not something that will control chronic edema. Next slide, please, Sheila. Okay, so we're on to assessment. So how are these people going to present? How are you going to find out that they've got chronic edema? Next slide for me. Okay, so the subjective assessment. So patients are often going to come in and they might be describing heaviness, aching, and discomfort. But lymphedema or chronic edema is generally not an acutely painful thing. So sort of watch out for that. They might describe tightness. They might be telling you that their clothing or jewelry is becoming tight. They might describe a sudden or a gradual onset, or they may be blissfully unaware that there is any swelling at all. And so objectively, you can often see the swelling. So they'll lose their bony prominences. They will no longer have, malleoli around their ankles. The pitting test is a common one, and it's a really easy one for many people to do. And just a little reminder, you need to be pressing. Ideally, you press for the pitting test for 30 seconds, but at least 15 seconds to get a reliable result. And you can see that picture on there is a beautiful example of pitting in that lower limb. The patients may have increased skin folds or creases. They may have a positive Stemmer's sign. So that's where you go to the base of the second toe and you try and lift that skin up. And generally, if there's edema in the foot area, you can't the skin, you just can't pinch and you can't lift it. You can often do it on your knuckles too, but you just can't lift that if there's edema around. There are often skin changes, particularly if the chronic edema has been around for a long time. So hyperkeratosis, that increased buildup, and papillomatosis, so that warty-like appearance of the skin. And definitely we see a lot, particularly with the venous disease, that hemosiderin staining. Lizzie showed pictures of that before. Atrophic blanche, lipodermosclerotic leg shape, so that inverted champagne bottle, and often really tight at that gaiter region, that leg shape there. and difference in limb size if they've got unilateral swelling. But remember, it can be unilateral, it can be bilateral, and we can often just sometimes see swelling of one part of the limb, like it might just be the foot or just be the hand. So it's not always bilateral. Next slide, please. Okay, so I've got some pictures here. Mostly these all are unilateral, and it just shows the difference, I guess. So you certainly can see that, on the edematous limb, you lose that visibility of the veins, you lose the bony prominences. On the picture of the knuckles there, you just lose that definition of those knuckles. And then the bottom left picture is just those stages of lymphedema. Basically, once they're getting to stage 4, I hope some management has happened for that patient, because hopefully ours aren't looking like that if we've been doing our best to manage them. So next slide, please. Okay, so obviously patients come in and you suspect they have chronic edema. The red flags, obviously, we need to rule out either DVT or cancer. So if they're describing a sudden onset unilateral swelling, if they're telling you they've got pain, if it's red, if it's tender, and if it's achy, let's rule out a DVT as soon as you can. So whether you're someone who can send for the appropriate investigations, or if you have to ask your patient to pop in to either see their GP very quickly or present to emergency. And obviously in that population, if they've got a history of cancer, any unusual pain or new symptoms could be related to the recurrence. So getting that checked out urgently is a good idea before we just treat the swelling. Next slide, please. And so management, and hopefully if we can work on the management, then we can, work on getting less cases of cellulitis. That's the plan. So next slide, please. So early management is really important because it is a chronic progressive disease. So once established, we can't cure it. We don't use the C word in our clinic because we cannot cure edema. We can stop it from developing into chronic edema if we get it really early. But by and large, once people have had swelling and for quite a long time, it's just going to continue unless it gets managed well. The good thing is it can be well managed, and particularly if you get to it early, and it's important for the patients to learn how to manage it early while it's mild. It's much easier, it costs much less for the patients and the health system. And realistically, patients need to know that if they ignore it, it will progressively worsen. So they will get an increased limb size, that the limb will weigh more, they will get tissue changes, fatty and fibrotic tissue. There will be skin changes. Skin will become dry, it will become firm, you'll get that hyperkeratosis. And then they have that increased risk of skin breakdown and wounds, and the increased infection risk is what Lizzie's talked about. So what are treatment options? And these are all sort of the tiles of the options, but I put the top 4 prominently because that's where I'm sort of hoping that you guys who are interested in this can help, particularly with our 4 to 10 month wait list. It's really great to get started on these treatment options before they see us, or they may not even need a referral to us if it's managed well. So we need to educate the patients about the chronicity, about the progressive nature of lymphedema, trying to work out why. So, are there any things that, that can be done to reduce that risk? Or, if it's a medication change, they need to speak to their GP about it. Exercise is really crucial, and it wouldn't be a talk from a physiotherapist if I didn't bang on about exercise. As Lizzie touched on, weight management is also really important. And once again, if it was easy, we'd all look like Barbie and Ken. So we really appreciate that it is a challenge, and skincare is certainly something that we can encourage. The next level down, compression, and compression is a really crucial part of edema management. But the earlier you can get in, the better. And I appreciate that many people in the audience aren't going to be qualified or skilled to prescribe compression, but there are options, ready to wear, custom made, custom bandaging compression pump. And the ones down the bottom are extras, and I sort of see of those as the bonuses. There's not as much research to show that they're really effective, and they're a bit of, as long as you're doing the top ones, then they can be a little bit of a bonus, bit of cream on top. So next slide, please. Okay, so if your patient has chronic edema, the first thing to do is educate them. Exercise, skincare, and weight management. Encourage compression. So you can refer them on to the lymphedema therapist. As I said, I'll be showing you how you can refer to us later on, but it doesn't have to be us. There are private lymphedema therapists. You can have a look on the Australasian Lymphology Association website for Find a Practitioner, so you can find someone who's qualified, and you can go to chemists. And just a bit of a disclaimer, I don't get any financial benefit from this, but there are chemists in Canberra who do provide a measuring service. So if you're looking at Capital Chemists, Charnwood or Mawson, they do provide a service, and sort of we do know that they have training in measuring for compression garments, but there probably are other chemists that do that. I'm just not sure exactly who they are, and I do believe there are some in Queanbeyan as well, but yeah, so suss that out and ask around to see if there's anyone who is skilled to do that, and it's certainly referring to us at North Canberra Hospital Lymphedema Service, but if you can get those other ones, the education of the other things first, that's great. So jump onto the next slide, please, Sheila. So exercise, as I said, it's strongly recommended. Physios always bang on about it, but it is so important because it improves lymphatic flow. Particularly walking is just such a basic thing, you know, to help lower limb lymphedema. Walking, it, you know, facilitates that muscle pump that helps that lymphatic flow. We always should be done in a safe and gradual manner. We're not asking patients to run marathons if they can barely, you know, get to their letterbox, but we just encourage that something is better than nothing, and they just need to do a little bit every day and gradually build up. And then don't forget strength training. Certainly those the exercise guidelines, the Australian government exercise guidelines, suggesting that we should be building up to 150 to 300 minutes of exercise per week, and that certainly can be broken up into little sections. But if possible, doing 2 sessions of strength training a week is also very beneficial. Next slide, please. Skincare. I'm not going to go too much into this because I think Lizzie and I really talk about the same thing. So skincare is just really important, and I think continuing to mention it when we have particularly male patients who come in and they've got very dry limbs and bilateral lower limb lymphedema, and you ask them if they've ever moisturized their legs, they look at you as if you've sworn at them. So we do just need to encourage people to moisturize, and we find we even need to continue to, you know, remind them. So we might tell them, and we know we've educated them on our first session, but we're seeing them 3 years later and they're obviously not moisturizing. So it can just be really simple skincare, just and explaining to the patients that your skin is protecting your lymphatic system. So if you let your skin get dry, it's much more likely to get cracks and holes and things like that, and that's where the infection comes in. Next slide, please. Weight management, as I said, it's not easy. I don't think, you know, we all appreciate how challenging it can be, but the reality is excess weight can impair lymphatic flow and venous return, which is why so many of our patients are morbidly obese. And we see it in the clinic. Healthy weight can improve lymphedema significantly. We see our patients who have significant weight loss and their lymphedema just improves so much. Generally, it's not going to go away because, as I said, it's chronic progressive, but it is so much improved if people can get to that healthy weight. And obviously, you know, it's not easy. So depending on what your area of expertise is, please reach out to the other people. So refer to GP, dietitian, nutritionist, refer to the obesity management service. I know they've got a very long wait list as well, but exercise physiology, psychologist, patients really need a team around them that can support them with that because it is a challenging thing. Next slide, please. So compression therapy is where we come in, as I said, or the chemist. So it assists lymphatic drainage by reducing lymph leaking into the tissues. So it creates a pressure differential. So we sort of want that fluid to get pushed into those collecting lymph vessels and head back to the venous system. And particularly when the limb moves, it assists the movement of fluid up the limb. And so if you put compression on when you're exercising, that's even better. So certainly if patients are asking you, oh, am I allowed to exercise with my compression or should I take it off? If they can safely do so, if it's not uncomfortable, please encourage them to do that. Now, as I said, patients can access compression garments from some chemists or through a lymphedema therapist. I've had patients access lymphedema garments online, and while we don't encourage it, sometimes I've actually seen some patients with I'll talk about general normal legs shape, they can actually get some good garments. So it's just about making sure that they're not painful or causing any circulation problems. And so lymphedema garments can be quite expensive, as Lizzie explained. We're generally looking to replace them every 6 months so they maintain adequate compression. But now some patients are eligible for funding through ACT Equipment Scheme, and the New South Wales scheme is Enable, Veterans Affairs, their home care packages, NDIS, and some patients have quite generous private health insurance. So it's important to sort of see if we can get some funding from those. Okay. So next. Okay, so compression garments. I think Lizzie and I have used the same picture here. You can see we worked in the same clinic. So they come in many forms. So there are wraps, garments, night garments. There's flat knit stockings on the picture right there. And as Lizzie also said, it is very important to individualize them, because bad compression garments are often, you know, it's better actually not to be wearing them if they're digging in or causing a tourniquet. They can be ready to wear or custom made, and that's where the ready to wear ones are often half the price. And if someone can start wearing compression garments before their limb distorts and they start to lose that, you know, inverted commas, normal shape, they're much cheaper for the patient. So getting them in early into compression is great, because yeah, custom made ones require specialist prescription, and usually cost twice the amount. So they may be flat knit or round knit. Round knit are sort of more likely the ones that you're going to get from the chemist. They're, you know, made a bit more like pantyhose, and they do tend, if someone's got pitting or really skin folds, they do tend to want to hug in there, and that's where it can cause trouble. And often that's your patients who are like, oh, I bought some compression stockings and they're really hurting me, so I can't wear them anymore. They might be patients who are going to need a flat knit garment, because it tends to sit better and not want to hug in at those smaller spots. You can get some of those from the chemist too, which is good to know. So compression garments vary in compression level depending on the patient need. So obviously the more severe edema, the more pressure we need. And it's also very dependent on the patient's ability to don and doff or apply and remove. So we generally, we frequently find ourselves putting patients in less than optimal compression, because we need them to be able to get in and on and off. Because otherwise we'll put them in these beautiful class 3 compression stockings that are just going to control their edema beautifully, but then they have to spend all week in them before someone comes around to help them get off, or they end up in the cupboard, which is a very expensive pair of stockings if they're not wearing them at all. We do encourage daily wear, and for some patients who have quite a chronic, you know, extensive edema, we might also encourage them to wear a night garment, and, you know, often need to be replaced every 6 months just because they wear out. Next slide, please. So I've just got some examples here. So it's a full leg flat knit on the left there for you, a half leg garment in the middle with an open toe, so that can be good for sort of checking capillary return. And then we've got a full wrap system on the right here. So that's actually 4 different wraps on that patient. So there's a foot one, a calf one, a knee one, and a thigh one. Obviously, we're only going to be compressing what we need, but we never leave the periphery exposed or without compression. So I would never put a leg wrap on without a foot, because we end up with a swollen foot. Next slide, please. Okay, so who can come to see us? Really, basically anyone who has chronic edema or lymphedema is eligible to be seen by our service. And at the moment, they're not even limiting which state people come from, as you can see. But maybe that's why we've got such an extensive wait list, I don't know. And so, or anyone who has signs of lymphedema. The other people we see are our cancer population, patients who are at risk of lymphedema, and those patients will generally get an automatic referral post-op. And so those who have had more than 5 lymph nodes removed from their axilla or their head and neck, or anyone who has had even 1 node or more taken from their groin, then they are at risk, they're sort of considered higher risk, and they qualify for eligibility for review for our service. Next slide, please. Okay, and so here's the big one: how to refer. So if you are a GP, the best way is to use HealthLink Smart Forms, so through your practice management software, and that generally is going to come straight through to our DHR. So the referral needs to be sent to North Canberra Hospital, NCH Physiotherapy, and make sure you select that lymphedema option. if you are a user of DHR, so you can, then you'll know what I mean by you can put an order in for an outpatient referral to physiotherapy, once again selecting NCH physiotherapy lymphedema. And at the moment, you can still send an email. So that one's up there. So chsnch.physio@act.gov.au. And we still do accept fax, 51036190. But my understanding is CHS is trying to phase out the emails and the faxes and try and really use DHR more. So my understanding is if you, for GPs and people who have access to HealthLink smart forms, there will be a period of time where, when they won't be accepting other methods. So sort of get to know that or find some support for that. Now, when you send your referral, or if you are going to, hopefully you've helped your patient, you didn't need to see us, but if you do send a referral, please include as much detail as possible. We have had referrals to say, please treat someone with swelling. And so that obviously takes us time. We have to go back and contact the referrer and work out where the swelling is and get lots of other details so that we can triage it appropriate. So we'd love to know the location of the edema, how long the symptoms have been there for, and if you have, completed any investigations. So if you're suspecting peripheral arterial disease, send them off for an ABPI at the same time so that by the time they see us, that's been completed. So it stops us then needing to send patients off. If you're suspicious of significant vascular disease, then certainly doing a concurrent referral to a vascular specialist is good, and it'll be interesting to see who gets to see them first. It's usually quite valid to do both of those. Any management to date, so if they're already in garments or not, or what they've tried, and a patient weight is really handy so that we know what size room to put them in, how long to triage for, and because we have had a particular patient, we sometimes get patients upwards of 300 kilos, and if we don't know they're coming, we can't prepare safely for them. And medical history, we want to know if they've got congestive cardiac failure. We want to know if they've got type 2 diabetes, chronic kidney disease, cancer history, or surgery history. We'd love to know if they've had episodes of cellulitis, and if they have a history of wounds, or if they currently have wounds. That would also be fantastic. And as I said, it just helps us make sure that we put them in with the appropriate therapist, because we don't want to scare off our juniors. We want to make sure that the really challenging ones are put with the senior ones. So thank you for listening, and I think we're on to questions now.
Thank you very much, Josie. Yes, you're absolutely right. We are on to our question and answer portion. Let me just see if I can get onto our chat. Just stop sharing. Okay, so we've got the first question here. Do we know why obesity increases risk of cellulitis, and if it's to do with the fat cells themselves or the understandable reluctance of larger patients seeking medical care that could prevent cellulitis, and thus it becoming a problem when it could have been prevented?
Yeah, I don't think there's specific research on why it increases risk, but it probably comes back to the sort of three main areas of vasculature, skin integrity, and immune function. And we know with obesity that it compromises lymphatic and venous return, and so it does cause swelling. With poorer lymphatic function, the immune response might also not be quite as good. And often there can be some, if there's some swelling related to the obesity, there might also be some skin changes on the patient's legs. So there's probably a whole lot of things that come together there that mean that result from obesity that increase risk. Does that help?
I think, yes, so I think that, yeah, that we can move on to the next question unless there's a follow-up question to that.
Yeah.
Thank you, Lizzie. And so the next one is, are compression garments only available for limbs? I can't imagine something for the neck.
I'll take this one, Lizzie. Absolutely. There are compression garments for the neck. You generally don't see people wearing them because we recommend patients wear them at night time, because the lymphatics of the head and neck drain during the day when we're upright, and then the swelling often will pool a little bit when people are horizontal. So that's opposite to what's happening in the arms and the legs. The swelling's usually better at night time when people are horizontal, but when gravity's acting. So there are compression garments for the head and neck. They are a little bit more specialized. There's sort of just a few generic ones that sort of wrap around the head and the neck, and it's hard often for them to tolerate that. But yeah, it's generally why you don't see them around is because we generally ask our patients to wear them at home or when they're sleeping, rather than out and about in the community.
Thank you, Josie.
I think I saw the next question. I think
sure.
that's that one's for me as well, I'd like to think. So specific exercises for lymphedema management. It's actually really interesting. There's a study going on at the moment about that with cancer, but it's movement. We want people to move. And so I think sometimes with our patients, if we're really specific about things, they're less likely to do it. So you want, using large muscle groups. So walking, it can be, lots of different things, but generally with patients, we find out what they enjoy and we try and encourage them to do that. So if they love swimming, that's great. Walking in the water is excellent. The pressure, the hydrostatic pressure of the water acts like a compression garment in the water. So if people want to do walking in the water, that can be great, particularly if they've got joint issues. But if they just want to, walk, that's fine. If they'd prefer to do some resistance exercise. So it's not, I don't think there's any real specific exercise. There used to be exercises they used to talk about in lymphedema management where you had to do a certain sequence and it was all very complicated. And I think we lost our patients when we tried to sort of do that order. And I don't really think there's any research to show that any particular sequence or any particular exercise is better than others. But certainly with lower limb, we want to get that calf muscle pumping. So have a think about things that are going to use the calf muscle, and walking's easy, even just standing, raising up onto your toes. So just using those muscles. So yeah, nothing particular, just find out what they love and get them to do it. So, or, any movement's better than no movement. Chair exercises, whatever we can get them to work on.
Thank you, Josie. So the next question that we've got here, what do you do when there's a discharge in the wound with limb edema, and if the limb is weeping with clear fluid?
Do you want to go, Lizzie?
Yeah, I think both of us could jump in there. I think if there's often compression is part of wound management. And so, particularly with venous leg ulcers, compression therapy is cornerstone of managing those sort of wounds. And if there's lymphorrhea, there's fluid leaking out of the limb, or if there's fluid leaking out of a wound, often compression therapy helps to stop that. And therefore it's a very important part of treatment because it will help to reduce that exudate. And so we do manage in the lymphedema service patients who have wounds, but we work very closely with specialist wound care services. And for those sorts of patients with complex wounds, we'd be ensuring that they're seeing appropriately trained nurses and wound management specialists that can decide what appropriate treatment is. And often part of that treatment would be compression therapy. Did you have anything to add there, Josie?
No, sounds good. Sounds good.
And I can see the next question is there more value in exercise than massage? Sure. I'm opinionated here, and I would say yes.
I think we both are, absolutely. I think there is very little evidence with manual lymphatic drainage massage. And so with our clinic, we teach people how to massage themselves, or if they've got a family member who's prepared to do it, but we certainly don't have the capacity to be providing lymphatic massage for people. And really, there's so much more evidence that the compression is going to work, and exercise is, certainly more beneficial. So if a patient is looking for bang for their buck, going for a walk is going to be much better than getting a massage. You know, a massage is expensive, it's time consuming, and certainly, you know, doing some exercise, which they can do for free, is going to be much better. You know, as I said, you know, I think of MLD and manual lymphatic drainage as a bit of cream on top. So if you're doing everything else and you've got the funds for it, go for it. You know, it's not going to do any harm. But if you're looking for actual things that are going to give you benefit for the time you're spending on it and the amount of money you're spending, then exercise, to me, absolutely trumps.
Thank you. I've got a couple of questions here from our GPs. How do you tell the difference between swelling with varicose veins, such as in lipodermatosclerosis, and with lymphedema?
So I think like when I was talking about chronic edema is swelling of any cause that's persistent, so has lasted more than 3 months. And so one of the main causes is venous disease. So as venous disease progresses, patients will develop chronic leg swelling. So they might start off with spider veins and then develop varicose veins. And as they get venous insufficiency and that blood's pooling, and there's increased pressure in the veins, more fluid is going to seep out into the tissues. And with time, the lymphatic system will start to fail as well. And so I think one of the things with chronic edema is our lymphatic system, when there's more fluid moving into the tissues, our lymphatic system should be able to keep up. It should be able to increase its flow, get rid of that excess fluid so that our homeostasis is maintained and there's not excess fluid left in the limb. But with time, when it's under constant pressure, as it is with venous disease, because there's constantly more fluid moving out into the tissue, it starts to fail as well. And so even though the swelling is in vascular disease and venous disease is primarily arising because there's pooling of blood from the veins, and fluid moving into the tissues, there's also a lymphatic component because the lymphatic system isn't keeping up. I always find it a bit hard to explain, but basically in patients with chronic swelling, it could be arising from so many different causes. Obesity and venous disease are two of the biggest causes, but there is a role of the lymphatic system there too, and the lymphatic system isn't keeping up in those patients. And I think actually just mentioning heart failure is another really common one where we manage swelling. And I think people wouldn't think that compression therapy is used to manage swelling from heart failure. But in patients where they've got well-controlled heart failure, but they're medically stable, maybe well-controlled isn't the right word, but they're medically stable.
They're not decompensating.
Yeah. So if they're medically stable and that care is optimized, they might still have some swelling. And for those patients, compression therapy can still help to minimize the fluid in their legs, and prevent
the leaking.
Yeah, prevent fluid leaking out of their limbs, prevent them developing wounds, things like that. So, yeah.
Thank you. So we've got another question here. Is there any role for lymphedema mapping?
Josie?
Okay, I'll get that one. So I think what they're referring to is ICG, so indocyanine green mapping. So there's a service that can be done. There's a clinic up in LinkedIn with Macquarie University that does that. So the idea is they are injecting a dye, turning lights on, getting their fluoroscope out, and they're actually watching where the lymphatics are flowing. It can be helpful. We have had some patients come back with, from the clinic with their map, and then, they might just have a particular area that they know, that's where they're going to target their personal MLD. So for some patients, they find that invaluable. They might work out that their hand's not draining up, the back of the dorsum, but it's actually coming through the palm of the hand, and that's sort of where they can target their stuff. However, there was some research that we were sort of made aware of a few years ago, and they compared map, because the idea of the mapping is to sort of help the treatment. Are they going to be then massaging, or what's the patient going to do? And so there was some research done. Was it in Belgium, Lizzie?
I'm not sure.
Okay, but they compared, complex congestive therapy with sham massage, indocyanine green mapping guided massage, and then sort of the true, foldy massage from the real purists, probably backed in Germany, and they didn't really find a difference. So that sort of leads me to believe, it's hard to know if you're just getting it to then have massage. I don't know. But if you're trying to understand what your body's doing, that can certainly help patients be more informed. And certainly I found patients become more empowered when they know what's happening in underneath the skin, because we as therapists understand the pathways that the fluid is mostly going to run, but everybody's different. Everyone's individual, and some people might have congested air in certain areas and not, and that can certainly highlight where those areas sort of, are backing up. So depends. Yeah. Have you got any more to add on that, Lizzie?
No. I think particularly it's more common in the upper limb than the lower limb. I think particularly in the lower limb, where you're talking about edema arising from conditions other than cancer or primary lymphedema, like sort of a fault in the lymphatic system that's arising from birth, there'd be little benefit. In the upper limb, maybe there'd be benefit at times, or if it's lymphedema arising from a genetic cause and you're trying to work out where the lymphatic system isn't functioning appropriately, I think then it's used at those sort of times. But yes, Josie's right in saying there's been some big randomized controlled trials that have showed that adding massage to care hasn't improved outcomes for patients.
Thank you. I think we've got time just for one last question, so I'm just going to read this one out. Is there anywhere you would suggest for patients to look for information and support?
Definitely. Yeah, the Australasian Lymphology Association would be the peak body, and the Lymphoedema Association Australia would be two areas, two websites within Australia that are good. The Australasian Lymphology Association is currently updating their website, so I'm hoping their resources might get a bit better soon. But also there's the Legs Matter website and the British Lymphology Society website, and both those come from the UK, originate in the UK, but they've got really excellent resources, particularly the Legs Matter website. So I'd highly recommend those.
And we might mention, Lizzie, the information for GPs. So if you jump onto the Lymphoedema Association Australia website, they've got a fantastic document, which is a guide for diagnosis and management in general practice. So that's a PDF, a couple of pages. And when I was looking at it, it really does summarize a lot of what I was talking about tonight. So that's certainly some information that patients can get, but also general practitioners. It's a fabulous resource that the LAA has written in conjunction with sort of the GPs. I think they're based in Victoria, but it's a great resource.
Well, thank you very much, both. And looking at the time, it's time to wind up. So thank you again for coming tonight, and thank you to Lizzie and Josie for such excellent presentations. Now, on Thursday, the 6th of March, at a similar time, we will have a presentation on Charcot foot, and this will be presented by our podiatrists here in the ACT. Please visit our events page for details on upcoming clinical education. This is also usually promoted in our newsletters and social media pages. Evaluation surveys for tonight's presentations will be sent out shortly. Please fill in the post-event evaluation survey so that CHN can email you a certificate of attendance after this event. And feel free to self-report 1.5 hours of educational activities to your CPD home. In terms of resources, presentation slides and YouTube recordings will be sent by email to all the participants who complete their evaluations. And again, thank you very much all, and have a lovely rest of the evening.
Thanks, Sheila. Can I just jump in with a little bit of a shout out?
Sure.
just a little bit of self-promotion. I don't benefit financially from this at all, I promise you, but Wounds Australia are doing, if you want to know more about chronic edema, Wounds Australia, if you jump onto their website, they're doing some education on chronic edema management as well. There's a webinar on the 5th of March that people can sign up for, and there's going to be a half-day workshop that I will help present, and we've got the wonderful nurse practitioner Cassie Luke who's going to be leading that with me. So if you need to know more and you want to do a hands-on session, then check out the Wounds Australia website for that.
Sounds wonderful. Thank you so much both. Good night, everyone.
Thanks. Bye.
Bye.